interesting case which I did recently. This is a 62 years old diabetic, had antral MI, thrombolysis with septokinase. After thrombolysis, he presented with ongoing chest pain and pulmonary edema. On admission, heart rate was 100, BP was 130/80, urea was 74, creatinine was 2.6, and saturation was 85%. So, in view of severe pulmonary edema, patient was not taken up for any procedure at that time, and he was stabilized with deaths. Even after big renal parameters were still elevated, and in view of recurrent angina, then patient was taken up for angiogram on January 18th, 2021, and BCG showed sinusitis, interval MI, and echo showed wall motion abnormality consistent with LV territory with LV dysfunction EF of 40%. So this is the angiogram. This is the right coronary artery, which has mild disease in the proximal part, and this is left coronary artery, and you can see the distal left main disease, and LAD was subtotally occluded at ostium and proximal part, and circumflex was having mild ostial disease with 50% COC in the proximal part. And this is another PA cranial view, shows the LAD subtotally occluded with the calcium in the proximal part. This is a levocaudal view, and you can see the very tight lesion in the ostium of LAD. So, patient after the angiogram, he got discharged, and initially we tried to manage this case with medical therapy, but the patient ended with again chest pain and pulmonary edema after 1 week, 10 days of discharge. So he had 2 admissions prior to the angioplasty. So what we decided in view of persistently elevated renal parameters with the urea of around 70 and creatinine of around 3. So we decided to do the case under fully IVS guidance, without any contrast use, or we able to use a minimal contrast. So after 1 month of angiogram, he was taken up for angioplasty, and you can see the LCX was wired and circumflex LAD was wired without any contrast use. This is a 7 French UV wide. And so we put this old angiogram as a roadmap. So with this guidance, the lesion was LAD lesion was pre-dilated with a 2 into 10 millimeter balloon. You can see the dilatation in the proximal part of proximal and ostial part of the LAD. So the distal left main and LAD ostium was dilated with a 2.5 into 12 millimeter NC balloon, and you can see the dilatation is going on at the distal ostium of the LAD and distal part of the left main. So then we put a IVS catheter, and this is the distal to the proximal pullback was done, and you can see the fibrocalcific lesions in the ostium as well as in the proximal part of the LAD. And so based on the IVS, the distal diameter of the LAD was 2.7 millimeter, and EM was 4.32 millimeter, and ostium of the LAD and distal part of the LAD, the diameter was around 3.5 millimeter, and you can see the there is a fibrocalcific lesion with 180-degree calcium in the ostial and proximal part of the mid part of the LAD. So based on this IVS image, we took another peridilatation balloons, So this is the IVS picture at the bifurcation point of the left main, and based on this image, the LCX is around more than 90 degree, so there was a less likely to shift of Carina, and the RCM of the LED, the diameter was 4.71 millimeter. So it helped us to take up a 4 millimeter balloon for another pre-dilatation. So the distal left main, the EM was 4.75 millimeters. So we decided to take at least 4.5 millimeter balloon for the parts. So these were the results we observed from pullback from LED to left main, and this is the pullback of LCX to left main, and you can see the. So based on this pullback, the LCX RCM was having the diameter of 3.27 millimeter, and EM was 4.8 millimeter, and there was a fibrocalcific plug. So the disease was only minimal. So more or less, we decided to go for a single stent strategy rather than a double stent strategy. So after adequate dilatation, the LED was the mid part of the LED to the proximal part was centered with 2.75 into 38 millimeter conic stent. And left main to LED was stented with 3.5 into 34 millimeter, another conic stent by overlapping the previous stent, and you can see another stent. So after the stent and overlapping the stents, the LED started developing slow flow. So immediately then we take a 4.5 balloon, and the pot was sent in the left main, and there was slow flow was persisting. So we took an aspiration device to deliver the drugs in the intracoronary. So intracoronary sodium nitroprusside was given, nicorandil was given 500 micrograms. So after the intracoronary delivery of drugs and flow was improved, and this small test injection was taken to check the flow in the LED. So with the thrombus aspiration device in the LED, you can see there's some stent was transparent in the mid part of the LED, and we took a 4 into 12 millimeter balloon, and it was aggressively dilated in the RCM and the proximal and mid part of the LED at 18 atmospheres. Then after sending the LED left main to LED post dilatation, we took a FFR wire into the circumflex to assess whether need for another stent. The FFR was 0.9. So in view of good FFR, there was no need to send the circumflex. Then this is the final check angiogram, which was taken to complete the completion sheet. We took only one check angiogram after removing all the wires, and this is the final result. And this is a preview, and this is a post result of the procedure which was done recently. So in this case, IVS really helped us to analyze the morphology and avoided the contrast use, especially in patients with the CKD patients. And pre-IVS evaluation without contrast has helped us to decide taking appropriate stent size and pre-dilatation balloon and post-dilatation balloon. And in this case, aspiration device used to deliver the deliver intracoronary drugs to improve the slow flow and assess the expansion as well as perforation by using ultra low contrast. And FFR really helped us to decide a need for another stent, and we generally another stent, so we avoided putting another stent in the circumflex. So thank you very much.
Dr. Subburamakrishnan.
Yes.
Yeah, I think you have done very well, and doing FFR to assess the circumflex was really the highlight of the case. And I just want to ask you a question. Is there a definition for ultra low contrast? Because in the studies, we know that the high contrast load is defined as more than 140 ml. But is there any definition to ultra low contrast?
I think
expression.
I don't have exact detail, but we can say around 30 ml.
Okay. All right.
The use of the IVUS, I think, gave enough room for it to reduce the amount of contrast, isn't it?
Yeah, yes.
I think this is one thing that most of us can utilize if you have it in your lab, especially for cases like this where there is a left main bifurcation complex stenting, and you could get away with a single crossover stent with optimal stent placement with the help of IVUS. A well done case. Only problem is, despite this thing, could you find out any struts across the circumflex ostium with your IVUS?
Actually, I have not done the post-stenting IVUS. Yeah, I have the post.
I think a post-stenting IVUS is a must, because even if you don't do a pre-stenting IVUS, if you are doing only one imaging, I will always go for a post-stenting IVUS because the outcome is based on optimization of the stenting. So optimization of stenting is the most important help or a benefit that is obtained with the imaging. Now,